Today we're going to be discussing schizophrenia and schizophrenia spectrum disorders. Epidemiology is about the prevalence of schizophrenia, which increases every year to even be from 0.7% of individuals worldwide and higher. It's one of the top 20 illnesses and has no discrimination based on race, social status, or culture. When it relates to comorbidities, substance abuse disorder has, along with that, nicotine dependence, in addition, anxiety, depression, and suicide. When it comes to substance abuse, 50% of persons with schizophrenia suffer from substance abuse. Alcohol and marijuana occur in about half of individuals with schizophrenia, and it can result and does result in a higher rate of treatment non-adherence. Other comorbidities include physical health or illness. Polydipsia is one of the common characteristics. That hyponatremia usually is created by, related to the antipsychotics that they're on. It causes dry mouth and it causes them to have polydipsia. And as a result, that taking in the fluid lowers that sodium. Also, it could be a part of the compulsive disorder that can be associated with schizophrenia. The patient is at risk for poor health maintenance, poor nutrition, substance use, medication, non-adherence, poverty, limited access to health care, reduced ability to recognize or respond to signs of illnesses, and receive poor health care, either related to the poverty, but more so the stigma and impaired ability to express their needs, along with stereotyping. Causes can be biological, can include looking at a biological factor, which includes genetics, a neurobiological, which is the dopamine theory. There are also other neurochemical hypotheses that are still continuing to be under research. And then there's a look at brain structure abnormalities. Looking at biological factors, research looks at genetics. And what research is saying is that 80% of individuals with schizophrenia have reported family history of schizophrenia. Other indication says that the biological factor is more related to an alteration in their dopamine transmission. These associations are related to the susceptibility of individuals developing schizophrenia rather than it being the cause. So we can't really say that genetics or the dopamine theory is the cause, but we can say it's a suspect for individuals with schizophrenia. Neurobiological talks about the dopamine theory. And so as a result, with that dopamine theory, it is medications like your first generation have been successful in reducing symptoms related to hallucination and delusions. These medications block that dopamine receptor, and without it, the patient would have dopamine hyperactivity, and that is what is the cause behind that psychosis. Because reducing dopamine activity does not alleviate all symptoms, other transmitters have to be reviewed and be treated as well. And so when we go into thinking of that, that's where your second generation antipsychotics come in, where they can also work on neurotransmitters that include serotonin and dopamine. And so your second generation antipsychotics will do that. And with serotonin also having a role to play in schizophrenia by using the second generation antipsychotics, it ends up working for your patient. When it comes to glutamate receptors, these are being studied because of the effect of PCP that is had on the sites that creates that psychosis. And then with GABA, it is impaired in individuals who have schizophrenia and may cause a role in their psychosis too. So when you, again, go back to the neurobiological, there are research that talks about the serotonin. It shows the serotonin, glutamate receptors, and GABA, when these are impaired, can result in signs and symptoms of that psychosis. And so that's why your second generation antipsychotics work. Looking at brain structure abnormalities, this could be something that has resulted in a disruption in the communication that happens within the brain with those neurotransmitters, and or it could have been a disruption that related or resulted in neurodevelopment issues. Other causes that can alter the brain's structure include inflammation or neurotoxic effects from oxidative stress, infections, or autoimmune dysfunction. And so so when we think about abnormalities, just remember that if there's an abnormality in the brain structure and the functioning, that it worsens with the disorder as the disease process continues. Psychological and environmental factors include prenatal stressors that include an infection that can increase the risk of mental illness. You also have psychological stressors, and then you have your environmental stressors. When we look at the course of this disorder, you start off with your prodromal stage. This is the earlier part, and this is much like the space in this space where individuals start off sometimes being misdiagnosed because some of the signs and symptoms of things that you're going to see are passed off as childhood development. So the changes will be mild. You might see they may have issues with tension and nerves, lack of interest, difficulty concentrating, no enjoyment or loss of interest, restlessness, and forgetfulness. And so these are very mild, and sometimes we have a tendency, individuals have a tendency of just saying, oh, they're just lazy, or things like that, or just wondering like who they're associating with or who they got into, versus looking at there being something mental. When it comes to your child, though, the earlier that there can be some recognition that there might be something going on, the better the results are, because that child will get early treatment. As we talk about the phases of schizophrenia, phase 1 is an acute phase in which there's an onset or exacerbation of the symptoms. In phase 2, they can have stabilization, which the symptoms begin to diminish, and movement is moved back to their level of functioning that they were at before the exacerbation. And then phase 3 is about maintenance, putting some distance between readmissions. It's about their recovery period. And we want them to be also back at their baseline functioning. General assessment is looking at positive symptoms, negative symptoms, cognitive symptoms, and affective symptoms. Positive symptoms are present of something that should not be present. Negatives about the absence of something that should be present. Cognitive is about subtle or obvious impairments, and especially when as it relates to thought. And affective is symptoms involving emotions and their expressions. With positive symptoms, they can have an alteration in their thought processes that can result in delusion. And delusion is usually the only explanation for changes in that false or fixed belief related on thought. Hallucinations really involve their 5 senses. With concrete thinking, it's an inability to think abstractly, so they're not able to understand punchlines, metaphors, or analogies. With Positive symptoms that include alteration in speech. They can have clang association, word salad, neologism, and echolalia. Religiosity can also be there, or magical thinking, paranoia, circumstantiality, tangentiality, and cognitive retardation. Alogia, or a poverty of speech or reduction in speech, flight of ideas, thought blocking, thought insertion, and thought deletions are other forms of positive symptoms. With alogia, there's a poverty of speech, flight of ideas, they go from one thought to the next, they're difficult to follow. Thought blocking is a reduction or stoppage of thought, usually interrupted by hallucination. Thought insertion is the belief that someone inserted a thought into their brain. Opposite of that is thought deletion, where they believe that thoughts have been taken out or are missing. With alterations in their perceptions, you're going to see things like depersonalization, so not feeling like something is real or having lost its identity. Derealization is a feeling that the environment has changed. Hallucinations can either be auditory, which is voices and sounds, command, which are auditory hallucinations, instructing them to have harm to themselves or others. It could be visual, so they'd be seeing people or things. Olfactory, which affects their taste. And tactile, which is feelings of bodily sensation. You're going to want to know and look up these alterations in behaviors. Catatonia is increased or decreased movement that can cause a nursing diagnosis of self-care deficit. Your motor retardation, you end up seeing a slowing of their movements. With motor agitation, they can have excited behavior. They can be either running or pacing. With your stereotyped behavior, you would need to know that there is repetitive behavior that they do not, that doesn't really have a logical purpose. With waxy flexibility, their posture is held into these odd positions, and they can do this for an extended period of time. Ecopraxia is the mimicking of movement. Negativism is a tendency to resist or reject the request or wishes of others. They can have impaired impulse control, which requires that we monitor them for safety. With gesturing and posturing, they can assume unusual positions too, but this is more related to their expressions. You might see them that they may be grimacing. And then with body impairment, that inability to sense where or be influenced by one's own body, or where one part ends and another begins. They have no awareness. When we think about affect, we're talking about that person's expressions of their emotional state. It can be flat, blunted, inappropriate, or bizarre. With flat, they're going to have a blank facial expression. With blunted, it's going to be reduced. With inappropriate, they could be laughing when there's a tragedy. So it's opposite of what you should expect them to see. And with bizarre, it's odd, illogical, inappropriate, and unfounded. They may also have difficulty with attention, memory, so that short-term memory is going to be impacted, as well as their ability to learn. They're going to have difficulty with information processing, and so there's going to be a delay in their response. There's also going to be some misperceptions, and they may have an inability to understand other individuals. We also want to make sure that we're looking to determine whether or not overstimulation can impact it as well. Cognitive flexibility affects their ability to change from two subjects to multiple subjects within a conversation. An executive function is about the ability, that difficulty with reasoning, setting priorities. It's about that part of the brain that kind of governs what we do. And so because they don't have that, then they are impulsive and have difficulty making decisions and can present as a risk to injury or harm to self. Assessment for depression is going to be crucial, and it's also difficulty because of the way they communicate. It may be hard for us to know. It can be caused by an inflammatory reaction that's happening in the brain as well. It may indicate a impending relapse. It may cause or increase use of substance abuse. It can impair their functioning and create an increase for suicide risk. So you have a patient with schizophrenia says there's a worms under my skin eating the hair follicles. How would you classify this assessment finding? And there are worms, so he's seeing them. So then that would be the presence of something that's there that shouldn't be there. So I'm going to go with positive symptoms, and that answer is A. When we think about assessment guidelines, we need to be assessing our patients to see whether or not they have any medical problems, assessing for abuse or dependence on alcohol or drugs. We need to talk about those command hallucinations and just ask them, are they hearing voices, and are those voices telling them to do something, and do they believe that they are real, because that determines whether or not they're going to act on it. And also determine the next part is whether or not they're a risk to others or self. And if they're saying yes to that, then that means we have to keep an eye on the patient. So you believe that a young man you're admitting to your unit is suffering from command hallucinations. What would be some questions to ask him? Well, you believe that the young man you're admitting is suffering. So if I believe it, I'm going to ask him questions. I'm going to ask him again, do you recognize the voices? Do you believe that these voices are real? And do you have a plan to follow the commands? Delusions, again, are something that we have to assess for, and one of the ways that we can do this is by asking the patient to tell us more about what their stress are, what they're experiencing before they begin to have these delusions. And then I would also ask them, determine whether or not they can do a reality check, and be able to determine what it is really real, and then determine whether or not the patient has believed that there is any danger, and then determining if they believe that not acting out these delusions, especially hallucinations, if they feel like not obeying them would cause them any harm. With suicide risk, I'm always going to be asking them, do they have thoughts that want to harm themselves? If they had the opportunity, what would they do? Do they have the ability to do so? And then from there, make the measurements necessary to keep them safe. And then to also determine whether or not they can engage in self-safety and maintain, one, Maslow's hierarchy of need, adequate food and fluid intake, and then determine if they have difficulty swallowing related to medications, and then talk about their sleep, their hygiene, and their ability to move about safely. And then we're going to talk about their medications and determining if they know how to take their medications, what effects and side effects and of those medications, so that they can build some type of trust for it. But I would also ask them questions like, how do they view medications, to determine the best route of treatment. With your mental status exam, we're going to be looking at insight, whether or not they have, we can reality check with them, looking at judgment, looking at cognitive abilities versus memory, content, abstract reasoning, looking at their knowledge of their illness, whether or not they have support within their family, and then also looking at coping and resources and what would they actually need. And then with family knowledge, it's really important with family that we determine, what type of family environment do they have. Is this a family that is overprotective, or is this a family that can be hostile? Would How do we educate them to prevent relapse? Do they have anxiety? Are they familiar with like support groups that are very available for them, and the understanding that there's also respite care or resources? Nursing diagnoses related to positive symptoms include disturbed sensory perception, risk of self-directed or other directed violence, impaired verbal communication, and your negative symptoms are about social interaction and chronic low self-esteem. So, how do we take care of our patient? When they are in phase one, we want to keep them safe because this is an exacerbation of their illness. We want to make sure that they are no harm to themselves. And then we also want to make sure that we're first ruling and looking at the physical issues and making sure there's no hypernatremia present. Then in the stabilization phase, we help the patient understand what that illness and the treatments are going to be, stabilize them on medications, and help them develop control over the symptoms, but also to be able to have that control with coping mechanisms. And then in the maintenance phase, we're going to maintain their achievement, we're going to prevent relapse, we're going to help them to be independent and have at least a satisfactory quality of life. After an acute admission, discharge is being planned for this patient. What are some things that need to be considered? And this is a patient with schizophrenia. And so we want to think about external factors such as their living arrangements, their economical resources, their social support and family relationships, and then look at internal factors such as their resilience and their coping skills. Other things that we can do is making sure that we connect the patient and the family with community resources, provide therapeutic programming and social uh, and financial support, and anything else that may be identified as a need. In the phase one of planning, which is the acute, the best strategies is about making sure your patient stays safe, making sure that we stabilize their symptoms, and they may need to be hospitalized if they appear to be a danger to themselves or others, or in the initial part of this is clarifying that this is the actual diagnosis. In phase two of the stabilization, the patient and the family receive education and support along with skills training, and it's through that they are able to begin to understand what that disease process is, what's actually happening to the patient. In phase three, this is the maintenance phase, and this is about furthering that patient and family education to help them to be able to identify those early signs that says that something is going on and may be leading to a psychotic episode. And if we can help them identify that to prevent relapse, then we put time in between their visits at the hospital. And it actually ends up having a better quality of life for the patient. Interventions during the acute phase include seeing a psychiatrist, receiving a diagnosis, and also having a neurological evaluation being done. We're not going to only assess their responses, but we're also going to be looking at side effects when it relates to the medical evaluations that they receive, especially if they're already on medications. We're going to continue with psychopharmacological treatments, and that could be related to the beginning of psychiatric medication or the reevaluation of their medications based on the response and side effects that says we need to try something else. We're going to give them support, psychoeducation, and guidance. We're going to make sure that we supervise them to make sure that they don't become a harm to themselves and intervene when necessary to not only protect the patient but also protect the milieu, because we also have to keep the patients, the environment, safe for other patients. And then we have to monitor their fluid intake, identifying when we see polydipsia, and then maybe doing fluid restrictions if necessary, and then doing lab works to check for sodium levels. In the stabilization and maintenance phase, again, medication administration is a continual part of this. Treatment adherence, relationships with trusted care providers, community-based therapeutic services, and then educating the patient and family not only on the illness, but also early signs of relapse, which is what the greatest impact that you're going to have for your patient. And it is your major role. Counseling and communication on hallucinations, making sure that we focus on understanding what their experience is and what their response is, and then making sure that we call the patient by their name, simplify loudly to be understood, and not loud as in yelling, but making sure that we're taking into consideration if they have these hallucinations, and that it may require that we give attention to that so that they're able to hear us and understand while they're having these auditory hallucinations. We want to make sure that we are presenting ourselves in a supportive way so that your patient doesn't, or so that your patient is able to build that trusting relationship with you that you should have with them. And then we want to make sure that we're maintaining eye contact, making sure that we redirect the patient and their focus of conversation. They just need that redirecting. And then we want to acknowledge the patient's experiences and feelings and convey empathy about their emotions and provide reassurance of what our intentions are, but also to avoid them from questioning those hallucinations. With delusions, we have to make sure that we see the world through the eyes of our patient and acknowledge their experiences and feelings, convey empathy about the emotions, provide reassurance of what our intentions are, but avoid questioning the delusion. Then we're going to focus on helping the patient feel safer, focusing on fear and the cause, and what can help the patient feel more secure is what's going to be therapeutic. With associative looseness, this is about disorganized thinking. So we don't want to pretend that we understand what the patient is going through. We want to place the difficulty in understanding what they're going through on ourselves. So we can tell the patient what we do understand, but then place the blame on us. We want to look for reoccurring issues that may be triggers, summarize or paraphrase our communication. Then we want to make sure that we are speaking concisely and clearly, but also concretely in sentences rather than the long drawn out paragraphs, and allow them to process the information, but then also to give them one piece of instruction at a time. With health teaching and health promotion, we want to avoid mistaken apathy and poor hygiene as bad behavior, create a warm, concerned, supportive environment, and recognize and respond to symptoms to negotiate to achieve change. Antipsychotic medications, including our first, second, and third generation medications, are pharmacological interventions that we can use. With your first generation antipsychotic, like your dopamine antagonist, these ones work on positive signs of schizophrenia. The advantage is that they're less expensive than the second generation. However, the disadvantage are the side effects that come along with the medication, including your extrapyramidal, your anticholinergic, your tardive dyskinesia, weight gain, sexual dysfunction, and endocrine disturbances. In your second generation medications, these treat both your positive and your negatives. They minimize the EPS and tardive dyskinesia, but the disadvantage for most of your patients is the weight gain. Aripiprazole or Abilify is your dopamine stabilizer that improves the positive and negative symptoms along with cognitive function and has less risk of extrapyramidal or tardive dyskinesia. There are some dangerous responses that can happen when administering antipsychotics, and these include your anticholinergic toxicity, and this is a life-threatening emergency and can affect your older adults because of the ANS instability and delirium. Hallucinations can be mistaken for psychosis if especially if your patient is of the older generation. And so when we start to see that they're having hallucinations, we might want to consider the fact that they have toxicity. With neuroleptic malignant syndrome, it happens with your first and your second generation medication and is fatal in about 10% of cases. It causes reduced consciousness, responsiveness, and muscle rigidity. It can result in DVTs, rhabdomyosis, which is a protein within the bloodstream, and that buildup of protein leads to organ failure. Agranulocytosis is another one related to the use of clozaril, and it puts the patient at risk for infections related to neutropenia. Additional medications that we can see our patients with schizophrenia on include antidepressants and mood stabilizing agents. Your advanced nurse practitioner may use other interventions including individual or group therapy, psychoeducation, medication prescription and monitoring, basic health assessments, cognitive remediation, and family therapy. So let's try a question. Loose association in a person with schizophrenia indicates, is it paranoia? I don't think so. Mood instability? No. Depersonalization? No. Disorganized thinking? Yeah. It's D. And last question. Which assessment finding represents a negative symptom of schizophrenia? Is it apathy? Maybe. B, delusions? I don't think so. C, motor tic? No. And D, hallucinations. Now I'm going to stick with A only because B, C, and D are positive symptoms of schizophrenia. All right, well that concludes this part of the lecture.